and various surgical videos at various national and international conferences. He holds special interest in surgical training of young ophthalmologists. So, welcome, Dr. Nikunj. Then let me introduce our panelist. We have Dr. Sourabh Patwardhan with us. He is director of Nandadeep Eye Hospital and PG Institute, Maharashtra. He is head FACO training and fellowship program. He is a chief mentor for FACO Tips 3D teaching course, which is a very unique program. He is pioneer in live streaming of surgeries on YouTube and Facebook for education. He is an inventor and he has iToric Patwardhan, which is Android-based app for toric marking, hybrid chopper, 3D surgical viewing system. He has performed more than 30,000 surgeries and he holds interest in cataract, retina, glaucoma, and refractive surgery. So, welcome, Dr. Saurabh. Then we have with us Dr. Varun. Dr. Varun is currently working as a chief consultant at Mahesh Netralaya. He has completed his fellowship in phaco and refractive surgery from Narayan Netralaya, Bangalore. He has published extensively in national and international journals and has presented papers at various national and international conferences. He has won Best Paper Award at UPSOS Lucknow in 2011 and AIUS Agra in 2014. So his areas of interest are phaco training and customization of refractive outcomes post cataract surgery. So welcome, Dr. Varun. Then we have with us Dr. Prashanth, who is currently in private practice. He was a former head of cataract and IOL services at Arvind Pondicherry. He has won Best Video in the New Producer and Young Physician category in American Society of Cataract and Refractive Surgery in the year 2017. He also won Best Abstract 2020 at Ophthalmic Society of Kenya for his work on 3D printed eye model for surgical training. He was a second runner-up in COVID Innovation Film Festival under AIOS for his innovations in wet lab training. He is a chief instructor in phaco development training program of ELCON, and his areas of interest are femtosecond laser assisted cataract surgery, secondary IOLs, and tech innovation in ophthalmology. We welcome you, Dr. Prashant. Then we will have a case presentation by Dr. Shail. So Dr. Shail is currently working as a consultant and refractive surgeon at Raghudeep Eye Hospital, Ahmedabad. He has won Best Paper in ASCRS 2015 for determining the elastic modulus of the Descemet's membrane stained with trypan blue using atomic force microscopy. He has won Best Video in ESCRS 2019 for Posture Perfect Ergonomics for the Ophthalmic Surgeon video. He has been invited for various national and international conferences. His areas of interest new and advanced technology related to cataract and research related to cataract. So over to you, Dr. Shail, for your presentation.
Thank you very much, Dr. Aarti, Dr. Nikunj, and the entire team at YOSI for creating this wonderful teaching initiative. And I think a video or a complication teaches us much more than reading tons and tons of textbooks. So I think this format is wonderful, and it's great that you have been doing this regularly so well. So congratulations to the entire team. I'll be discussing a fairly, straightforward standard scenario. So this was a 64-year-old male who was, planning for cataract surgery. And if you can notice, the pupil is not very small. The pupil is not very dilated. And because he had significant regular astigmatism, we had planned for a toric IOL for him. Notice here that before we start the surgery, the glow is good, but you can see a lot of this opacification coming from the posterior capsule. So these are sometimes tricky cases where you feel that the cataract is not very dense and the glow is good, and therefore you must, you'll be fine in doing whatever techniques that you are used to doing. But quite often what happens is that when we are actually doing the rexes and when it comes to the area of these posterior subcapsular or cortical cataracts, we end up losing the flap quite often. So I find staining as a very cataracts and not just white cataracts. And I think it's there is no absolutely no harm in staining. I did this under air bubble, but you can do it even without the air bubble. Capsulorhexis starting point, it's very important that whatever maneuver that you do in cataract surgery, even the smallest maneuver, it should be done thoroughly and under good focusing. So if you notice here, the focusing is still not crisp. If you notice here, the cornea is not so clean, should have been washed more thoroughly, or or a bit of methyl cellulose should have been put. And after a lot of hesitation, the nick is being created. So if you notice here, the nick was initially aimed. If let's go back here, the aim was to start somewhere from here, but the cystitome positioning was not correct, and ultimately when it hits the capsule, we end up making a start quite much to the left of the center of the midline. Now what this does is it does not block your step of making or starting the flap, but what it does is gives a very small leverage. So although none of us are good at physics, but the fulcrum liver experiment shows us that if you have a larger liver, fulcrum, it's easier to rotate over it. So notice here, the flap is not everting very easily because the flap is short, and what that does is you end up making a smaller beginning or a smaller opening. Once you do that, you're always playing catch up. So right now what we are trying to do is we are making a very small rexis because we have realized that we have made a very small rexis to begin with. And the iris should be used as a guide for the starting point. Now it's very important that you maintain a fairly uniform distance from the iris, whether it's a small pupil or a large pupil. But smaller the pupil, more the leverage you have to go very close to the iris. In large pupils, we sometimes end up making two larger X's, and in small pupils, we sometimes end up making one larger X. Although the gap or distance from the iris is fairly uniform so far in this Capsulorhexis, but if we actually go back and look at the larger picture, this pupil is hardly 5 or 6 millimeters at the most, and we are at least 1.5 millimeters inside that iris. So this rexis is unlikely to be anything more than 4.5. While turning, what happens quite often is that this flap bunches up. So if you notice here, the flap is actually this one, and this part here is actually the overlying unfolded capsulorhexis that has occurred. So the best thing at this point of time is to push this flap away so that you can work directly on the actual upturned flap. And what most of us end up doing is, in our hesitation to push it away, we end up doing it blindly on top of this loose flap. So sometimes this can be dangerous, and you can create a few nicks here in the intact anterior capsule. And once again, it's a very important thing to try and overtake the area of the starting point and not create a very sharp joining point or a joining curve. In the end, it appears to have gone off quite okay. The Rexes seems to be, have been made a little bit smaller, but there's nothing very untowardly that has happened. The only probable drawback would be that there's a very sharp joining here, which is probably not the most ideal thing. So at this point, I would like to take a pause, and I think we can discuss some of the nuances of capsulorhexis, some points that come to my mind, which I would like to ask the others as well in the panel and in the audience, is what are the cases where you feel is a good idea to stain the capsule, or do you recommend staining it in all cases for the first few hundred cases, or so on and so forth? So what's the opinion of the others or the panel regarding this?
Uh, well, Dr. Shail, as far as I'm concerned, I generally stay in all my cases because it is not just about the rexes. Also, when we are doing cataracts, when we are chopping, uh, uh, slightly stained capsule gives you a certain idea of how far you can go, and especially it becomes relevant at the beginning of your career. But that is something which I have kind of incorporated, and I don't really see any harm in that unless and until you're a very high volume surgeon and that extra step is taking a few seconds more for you. I would, especially for the younger people and the people starting out, I would definitely advise staining the capsule because it makes life that much more easier.
And also
Yeah,
regarding the sizing of the Capsulorhexis, Dr. Patwardhan, we've learned so much from your videos. Would you like to share your tips on sizing and how you go about your Capsulorhexis?
yeah, sure. So regarding the staining, I think three things are important. One is your experience. If you are experienced, you can avoid staining. Because your experience, that means even during phacoemulsification you don't need to see the rexis all the time. That is the thing. Second thing is what microscope you are using. So if you are using microscope which has brilliant retroillumination, then most of the cases we don't need the staining. And I think the third thing is the type of cataract, as I think Dr. Shail has rightly mentioned. Very good glow, but if there are areas where the glow is not good, then you may land in trouble when you are going through those areas. So I think in those cases also it is better to stain rather than not stain. I think for sizing, if you see Dr. Shail's video, I think he rightly pointed out that he started off small and then it kind of continued being small, and the small pupil was the template for doing the rexis here. And that happens very often, that if the pupil is too dilated, you tend to making a big rexis. If it is small, you tend to make smaller rexis, because we are very sensitive not to just the diameter of the pupil but the area of pupil. And area of pupil drastically reduces when the pupil is smaller, so that's why the size of the rex is also going to be smaller. So for sizing of the rexis, I think there are many things which are available. With experience, you don't need any of these. I think Dr. Shail had access to the image guided system, which he showed initially. That's a good tool. But if you don't have that, then a simple the optical zone marker of Lasik can be used. So what can be used is a 6 mm marker. So when you use a 6 mm marker, you just make an impression on the epithelium. You don't need to stain also, and that stays there. And with 6 mm, you generally have the impression on the anterior capsule about 5.3 millimeter, because there is a 12% magnification of the cornea which is there. So if you are using 6 mm marker, you approximately you have a 5.3 mm rexis on the capsule. So that is the guide. If you use 5 mm marker, then it will be even smaller, say 4.7 or 4.8. So I think 6 mm marker is good way to go about. I have developed one marker. Actually, this was the first idea by Dr. Banaji, Burjor Banaji, who had created a Rexis marker. And he also had another modification where he had two rings. So one was 5 mm, one was 6 mm. So you can go in between the two marks which are there. I made another modification where I, instead of ring, I made dented processes. So you can have something like a ring of, 8 points. So it doesn't disturb you. And for beginners, you can in fact even stain those processes. So you can have kind of small dots which stay there when you are doing the capsulorhexis. So in case you cannot see the epithelial marking, which is enough in most of the cases, if you have a good microscope, you can also stain. So I think these are my, and you should have at least 5 mm rexis, particularly for beginners. Whenever I train fellows or trainees, if the surgeon makes less than 5 mm rexis, we first enlarge the rexis and then only allow the trainee to go ahead, because I think small rexis is root cause of lot of complications, particularly in beginner's hand. An experienced surgeon can get away with even 4 mm rexis, but for beginners, I think 5 mm is must. Even if you have an eccentric 5 mm rexis, or you don't need to be exactly circle. It can be oval, it can be pear shaped, anything, but it has to be at least 5 mm for beginners at least.
Okay, so I think
I
having done the
yeah
capsule, sorry.
yeah. So I just a small. As I wanted to just suggest that staining of the capsule is initially, I think, for all beginning surgeons, staining is a must. Probably in the learning phase is one, and as you become experienced. As Saurabh told, if you're having a very good microscope with a good retroillumination, then NS2, NS3 cataracts, you will probably be able to do it well without the caps staining. But that again, you have noticed that in white cataracts, definitely the staining is going to help. And also, you must have found in pseudoexfoliation and younger patients, sometimes where the capsule is very elastic, staining the capsule helps to reduce the elasticity so that you can get a better control of the capsule. That is one part which studies have already been published and proven that how staining of the capsule helps reduce the elasticity is one point. And sizing of the Capsulorhexis, I think particularly even in cases like pseudoexfoliation, which is less than 3 millimeters, or even contraction of the capsule of intraoperative size of less than 1 millimeter can cause phimosis. So those cases we need to be very careful to maintain the capsular size. And of course, when you're dealing with the dense cataracts, you need to make a larger rhexis to do that.
Thank you all for these wonderful inputs. So, having done the capsular X's, the next important step is to do a good hydrodissection. And I think a good hydrodissection done makes a lot of life easy. If the nucleus is freely rotating, it makes life quite easy during the steps of cataract surgery. So, like you notice here, the rhexis is a little bit small, and the joining point is a little bit sharp, but nothing appears to be anything very abnormally wrong at this point of time. And this is a bent cannula that we have modified from Dr. Akaoshi from Japan. And we find this cannula useful. And we go ahead subcapsularly and inject fluid, and nice wave of fluid has gone through. But notice what has happened along with the nice wave of fluid. Notice again here that as the wave of fluid passes, it has split this capsular axis, and it has split just before the actual joining point. Although we could not actually figure out where, I mean, what exact area the weak point might be during the making of the capsular axis, probably the maneuvering did make some weak areas there, and it has led to a split in the capsule. So at this point of time, I think we would like to pose a question to the audience, and let's take an audience poll as to, if you end up in this situation, what are the things that you would do further in this case. So if we can have the audience poll question.
Dr. Gunjan, can you put the question, please? I think there is some technical issue with that. We'll take the poll at last. I think Dr. Shail, you can continue, please.
Yeah. So the first question at this point of time that would come to my mind, and oh, sorry, yeah, we have the question here, and I think this is the most relevant question, that if you have an anterior capsular tear before the start of phacoemulsification, what should you do, or what would you do as your next step? Would you convert to an SICS or an extra capsular? Would you continue phacoemulsification with low parameters, or you would call your senior or your colleague for help to take over the case? So I think we have 30 seconds for polling, and the time starts now. So I think that's a very positive poll that we have seen. Up to almost 80% feel confident that they can continue with phacoemulsification with low parameters, even when the capsulorhexis split has occurred at such an early stage of cataract surgery. And we felt the same way, and we decided to go ahead with cataract surgery with phacoemulsification in this manner as well. So the important point here now, that now that this area is weak, two things that we want to make sure. we want to make sure that this flap, now this anterior capsule extension, doesn't extend to the posterior capsule, leading to a PCR or a drop nucleus, because the entire nucleus is in the bag. To achieve that, we need low fluidic parameters phacoemulsification. So here we are using a low IOP of 30. You need not have a machine which controls IOP, but an IOP of 30 is equivalent to a bottle height of about 50 centimeters. So whatever your bottle height normally is, if you're using 90 to 100 centimeters of bottle height, drop it by at least 30%, so that you don't have too deep a chamber and too much of fluttering. Also, an important point to notice is to reduce the aspiration flow rate. So if you notice here, the flow rate, I've set it at 20 cc per minute. So normally if you are using 30, 35, 40 cc per minute, here at this point of time in this situation, you want things to be happening very slowly, so that even if it takes more time, everything is happening under your control. And make sure that all the fragment removal and all the maneuvers are being done in the center of the eye, in this zone, in this area of nice intact capsulorhexis. So don't manipulate your probe, don't manipulate your instruments to grab fragments from different areas, particularly from the area where there is a split anterior capsule. And once again, use low parameters even during fragment removal, with a low bottle height and a low aspiration flow rate. Of course, you must use appropriate power and appropriate vacuum to remove the cataract. This is a dense cataract, but not a very dense cataract. So this was in that sense an ideal choppable grade 3 plus cataract that all of us would want in our OT list to be filled with. And once the last fragment is released, the most important step of surgery is now here. So do not withdraw your phaco probe before forming the chamber, because any collapse, sudden collapse of the chamber, a sudden forming or sudden deforming of the chamber, will have a very high propensity of letting this tear extend to the posterior capsule. So before withdrawing your phaco probe, inject a viscoelastic with your other hand, preferably a dispersive viscoelastic, but definitely not a cohesive viscoelastic, because the cohesive viscoelastic will come out as a bolus. And only once the chamber is formed do you go to foot position 0 and then bring out your phaco probe. Cortex removal is challenging, but I think in this is the case where even if you're not generally doing bimanual irrigation aspiration for cortex removal, you should do. The reason why I would suggest that is that while using the main incision, quite often what happens is that there's a lot of maneuvering at the main incision, which leads to sometimes shallowing of the chamber. And this is the eye where you don't want any form of sudden shallowing or sudden forming or deforming of the chamber. So even if, for example, here I had a very small side port, I didn't have an intention of doing the bimanual completely, but I made that into a normal side port, through which I can enter my aspiration probe, so that I have good access on both sides, and there is no subincisional cortex or there is no awkwardness in the chamber. So I can maintain the chamber in all directions from all ways. Even while swapping from one hand to the other in the bimanual irrigation aspiration, you want to make sure that the chamber is followed, formed. So before withdrawing my irrigation probe, I formed the chamber with dispersive viscoelastic. And notice the foot pedal and the vacuum. So when I'm occluding, the vacuum is only about 80 to 100, and only when I bring it to the center, particularly in this area, when I'm sure that I've caught nothing but the cortex, do I step up on the vacuum. So do things slowly. It may appear very tedious, it may appear very time consuming, but this is not the case where you want to rush to your next case. Some fine polishing of the posterior capsule. I generally do not do anterior capsular polishing, and we found in our study as well, including histopathology logical study, that it really doesn't make any difference to the PCO that is created. And after the irrigation aspiration is done, once again, make sure before withdrawing your irrigation probe that the chamber is formed with viscoelastic. So now we are in this situation of this small 3/4 good cover rexes and the split of the anterior capsule. Fortunately, it has not extended to the posterior capsule. So in this situation, I would like to take the opinion of everyone here. as to what exactly would be the preference in terms of the type of IOL to be injected, and I think we can take an audience poll for that. So if Dr. Gunjan can put up the audience poll question here. So we'll take the first question first. If there is an anterior capsular tear and nucleus is removed, cortical wash uneventful like this, which IOL would you implant? Would you implant if the patient is already planned for a toric IOL? Would you implant a single piece toric IOL in the bag? Would you implant a single piece non-toric IOL in the bag? Would you implant a three-piece IOL in the bag, or would you implant a three-piece IOL in the sulcus? And the second question is, if in this if this case would have ended up with an extension posteriorly during INA, would you abandon the procedure and refer to a VR colleague? Would you check for vitreous prolapse yourself, do anterior vitrectomy, and then go ahead with single piece IOL in the bag? Would you check for vitreous prolapse and do anterior vitrectomy with single piece IOL implantation in the sulcus? Or would you check for vitreous prolapse and do anterior vitrectomy with three-piece IOL in the sulcus? So I think the time starts now. So more than 50% would still go ahead with a single piece toric IOL in the bag. Um, 33 a large chunk would go ahead with single piece non-toric IOL in the bag, and I understand from where that is coming, because we want in a toric IOL the rotation to be not occurring, and if you are not sure whether this IOL will stay in the bag or will not rotate, it may cause difficulty. So, having had some similar experiences in the past, we did decide to go ahead with toric IOL implantation in the bag. If you have a good 3/4 anterior capsulorhexis cover, it's generally these IOLs will stay put. So there is very minimal chance of this IOL popping out of rest of the capsular bag and ending up in the sulcus. So that's not something that we are worried about. Always use a cohesive viscoelastic to inject, particularly in such a case, so that it comes out as a bolus. Fortunately, in this case, the placement axis was away from the capsulorhexis tear, and therefore was not so much of a challenge or so much of a decision point to decide. But a similar, and this is what the patient ended up at the end of surgery. And we had a similar case just a few days later, where the capsular rhexis is split right in the area of phacoemulsification, again a small rhexis, and probably it might have been created by the chopper while trying to chop, as this capsular rhexis was not stained. Here, the tricky part was that the placement IOL was right exactly in the area of the capsular rhexis split. So once again, inject the IOL under cohesive viscoelastic, a slow, because it will allow the IOL to open slowly. So you have lot of time to maneuver, and there is no sudden jerky movements occurring anytime. Make sure that the IOL is completely in the bag. And then, having removed the viscoelastics, you want to make sure that the IOL is then not only in place but also rotated in place, which we found here was aligned appropriately. And notice here another important point, which I failed to mention previously as well, that you always hydrate the wounds before letting the chamber collapse, particularly in a case of split capsule. So the capsule can extend even at this point of time. You want to hydrate, but you don't want to overhydrate to the extent that it splits. And this is what it was at the end of the table, centered on axis. We were a little concerned as to what this will end up post operatively, because the placement axis was in the split area. But this is the patient 3 months post operatively with practically no rotation of the IOL. So in both cases, as you can notice here, the problem probably started with a very small rhexis, and In one of the cases, it started well before cataract surgery. In this case, it was noticed just at the end of phacoemulsification and before irrigation aspiration. So I think toric IOLs or any single piece IOLs can be considered to be placed in the bag if you have a good 3/4 degrees of anterior capsulorhexis cover. If you have any posterior posterior capsule dehiscence, I think it's mandatory to look for vitreous with triamcinolone and consider placing a single piece in the bag only and only if you are able to convert that PCR into a strong PCCC or a posterior capsulorhexis. If you are unable to do that, then I think it's not a good idea to place a single piece IOL in the bag. And the best option would be to place a three-piece IOL in the sulcus. And a single piece IOL in the sulcus is absolutely a contraindication and will prove lethal in the long run with uveitis and glaucoma. So these are some of the things that I learned tremendously from these two cases of toric IOLs with complications. And I would value the inputs of not only the panel, but other, if there are any other questions that anyone would like to bring out.
There was a wonderful presentation, Dr. Shail, and it was beautifully managed and very nicely recorded cases as well with a beautiful outcome. And I want to congratulate you for that beautiful case management and for your presentation. So first, I want to start, as our viewers are also so many of you young surgeons and residents and fellows are training. As in this video, Dr. Shail also pointed out that during the access, there was a possibility of multiple micro trauma where the flap was folded up. So I want to ask our esteemed panelists, all of them are involved in training surgical fellows, that what is the preferred method you teach for capsulorhexis? Either is it using cystitome or using the Utrecht or other capsulorhexis forceps? Saurabh sir?
Yeah, regarding whether to use cystitome or Capsulorhexis forceps, I think both are good methods, but cystitome is better, particularly for beginners, because you can go through a small side port. So the anterior chamber maintenance is good. When you use a Capsulorhexis forceps from the main incision, the main difficulty that beginners face is that they tend to press the posterior lip of the incision a lot, and that leaks the viscoelastic. Now, if the trainee has access to a good OVD like say Viscoat, which maintains itself, so in the initial learning curve, that will definitely help with the forceps, because the beginner doesn't have to worry much about the visco leak. But there are cost issues using Viscoat in all cases. So with methyl cellulose, using forceps a bit difficult. If someone has already trained himself with forceps, then I would let him continue with that, because both the techniques are good. You have to be master at least one of them, and cystitome for uninitiated is a better option to have. And another option for forceps is a microcapsulorhexis forceps, which can go through the side port incision. I think for beginners that is better than using forceps which go through the main incision. Yeah, and congratulations to Dr. Shail. I think wonderful demonstration of how to go about in a case where there was a tear. And I think he very rightly pointed out all the phaco parameters where used low IOP phaco, which I think is the key to the success of the surgery. And apart from that, he rightly pointed out later the hydration of the incisions when he was taking out at the end. That is particularly useful when there is a tear at the point, like he showed in the second case, where he want to place a toric IOL in the area where there is a tear. And if at the end, if you don't hydrate the incision and the AC kind of collapses, that haptic tends to come out through that area where there is a tear. If it is on the other side, it doesn't matter. But if it comes out, then to put it back is a difficult, I think it will be difficult. So he has shown it beautifully. And apart from the toric, there are two types of toric. There are plate haptic toric also. I think what Dr. Shail used is the IQ toric IL, which is I think excellent for such cases where there is a tear. I think handling a plate haptic torical will be difficult. Any experience, Dr. Shail, with the plate haptic torical?
No, unfortunately, I've never used a plate haptic, even non-toric. I've always used C-loop haptic IOLs.
Actually,
I think in such scenarios,
yeah,
this
Dr.
this is
Saurav,
not
actually,
a
you're
good.
right. With or without a tear, using a toric plate haptic toric is actually a difficult thing because we used to use the Zeiss toric when we were in Bangalore. And it does not really dial so well if you inject it in the bag in the first go. So what we used to do for the rough alignment that you do immediately after injecting the lens in the bag and taking out the visco, we would actually leave half of it outside the bag. And then we would turn it and align it in the final orientation and then put it inside the bag, because once the plate haptic goes inside the bag, it is very difficult to maneuver it. And more so with a, torn anterior capsule, if you maneuver it within the bag, the friction that it's going to cause is probably almost always going to make the capsular tear extend posteriorly. So yeah, a C-loop haptic in this situation is definitely a better option.
And another thing about plate haptic torical, as you rightly said, it's difficult to rotate when it is in the bag. And if it is very easy to rotate when it is in the bag, then in fact it is going to rotate post-operatively also. So that's not a good choice for that particular case. So if you have a patient with possibly a big bag, it's better to avoid a plate haptic torical and go for this kind of a torical, which is better for such cases.
Yeah, so since we are discussing Capsulorhexis, I have a question for Dr. Prashant. Can you just give us some tips and tricks to get a consistent Capsulorhexis size and how to avoid it from extending?
Thank you. And of course, Dr. Siles, congratulations for the wonderful video. As with both the questions, Nilkanj and Aarti's questions, actually, initially we start, the training part we do with the needle and then with the forceps also. And as Saurabh told, sometimes as the AC shallows, most of the times, a very important factor for the Capsulorhexis extension. So sometimes in the needle, what we do is we can keep a second bend in the needle, which actually hinges the roof of the tunnel. So this second bend in the needle can keep the roof up, which invariably helps for egress of the visco out and maintains the chamber. A little modification of the needle can be done. As many of times when surgeons start learning capsulorhexis, their main focus is going to see the number of points in which they're going to make the circularity or get the centripetal forces bringing about the rhexis. But what happens is they don't realize the fact that once it collapses or it becomes shallow, there is a convexity of the capsule which is going to come, and that causes the extension to take place. Coming to your question, Dr. Aarti, on the size of the capsulorhexis, of course, there are various techniques of initiating the capsular flap, where you make a C-shape capsular flap, or people some to make a radial tear and then dip down the capsule and elevate the capsule. So sometimes when you mark point from the center to the mid periphery, the millimeters that you can actually count also can help to determine the radius and guide you to the circularity. And as most probably calculations of 180 degrees to 270 degrees is the most likely points that you may find a capsule to getting extended. So as I told you, maintaining of the anterior chamber is very important during capsulorhexis, and keep managing to put more visco to maintain the anterior chamber. And in case you find your capsulorhexis extending, and I would suggest the very famous and well repeated technique of the Little's capsular rescue technique, where when you find the capsulorhexis actually going to extend, stop there. Try to unfold the flap back into the nucleus, into the anterior surface of the nucleus. And once you've unfolded the flap back into the anterior surface of the nucleus, use the forceps, grasp very close to the tear, at least to the base of the nucleus tear, pull it towards the center. That is, the perpendicular forces are going towards the center of the capsule. And then you make an arc and then you bring back the flap and go. So the little rescue technique has always been a very safe technique and very good reproducibility in bringing back the rescue. Of course, I know there'll be various other techniques you can do to manage, but identification at a very early stage is very important to get a good, safe Capsulorhexis.
So, Dr. Saurabh, you have been training so many students under you. So, I have come across something called as rule of center of triangle. So, can you please explain us?
Yeah, I would like to share that video. It's not something unique or different, but I feel when you are operating, you cannot observe too many things at a time. So you cannot see the bigger picture. So if you have certain rules to follow, I think it makes your, any procedure more repeatable or reproducible. So I will share that video. I think it has audio also with it. So let me play. Yeah, here is the video. So just let me know if you can. Is the audio?
Yes, we
Let's
can.
investigate the rule of center of triangle. We cataract surgeons know that capsulorhexis is the most essential part of the surgery, and we commonly use the cystitome made from 26 gauge needle. And in a regular case as well, we find this happening. The capsulorhexis, which is going on smoothly, suddenly starts going outward. And when I looked into detail of the maneuvering of the cystitome, I found that I was holding the flap at the wrong position. This led me into investigating all my cases, the surgical videos, and finding out what goes wrong and what should be done to make it right every time. And that led me to formulating the rule. I call it the rule of center of triangle. This is the rule that will help me in all my future capsulorhexis to get a very reliable and reproducible capsulorhexis. So what is this center? This is an imaginary triangle of 1 to 2 side each, and the apex of this lies at the advancing tear, one side along the flap fold and another side along the flap margin. When your cystitome holds the capsular flap at the center of the triangle, we get maximum control over the further movement of the flap. So that is the rule of center of triangle. So let's find out this case where I am demonstrating the rule. This is the first radial tear which is made, and then the flap is folded. Folding the flap over the anterior lens is very important. Now you can see that imaginary triangle, and I am holding this flap at the center of it. The moment I advance the flap, again a new imaginary triangle is formed, and I am going to hold it at the center. So this will keep on happening all around as I move my capsulorhexis around. This is more useful particularly in the subincisional area, that is where there is a higher risk of capsulorhexis going out. So again I am carefully imagining the triangle and holding at the center of this triangle. To look it further into detail, you can find this imaginary triangle here, and I am careful to hold that flap at the center of this triangle, giving me full control over the movement of the flap. So as the capsulorhexis advances, I will be repositioning my 26 gauge cystitome at the center of the triangle and advance the capsulorhexis further. These are the common errors when we don't follow this rule. First error is when you are holding away from the tear edge, nowhere near the center of the triangle, and this leads to uncontrolled flap advance. When the flap advances uncontrollably, it may go outward into the zonular area and may lead to Capsulorhexis extension. And you will find this in your previous surgical videos, that this is the common error which happens when you have extra large Capsulorhexis or the rhexis going into zonules. So to bring it back again, you have to hold the flap at the center of the triangle. Just watch here how I do it. That gives further better control over the Capsulorhexis and bring it back. The second common error happens when you lift the flap at the flap fold. That is very common and very subtle error. You can find here that whenever the cystitome holds the flap at its fold, the direction of the Capsulorhexis tear immediately changes. And this subtle change in the direction of the Capsulorhexis will lead to further enlargement of the Capsulorhexis. So after forming this rule, I went through lots of videos and also started using this rule in my day-to-day surgeries. I found that this rule was exceptionally useful for me to get reproducible and well-controlled Capsulorhexis. So the rule of center of triangle is going to help us in getting a very good Capsulorhexis in all our surgeries. Though of course some basic rules we have to follow, like maintaining the anterior chamber, keeping the flap folded, using heavy OVD in difficult cases, and maneuvering through small incision. And then we can get a very good result in our Capsulorhexis using the 26 gauge cystitome. Thank you very much, and do apply this rule in your next surgical case. Thank you.
Okay, so that was the rule which will help us. I think next time, whenever you go back and you are doing your case, just see whether this rule will help you in getting a good Capsulorhexis.
Thank you, sir. That was an excellent video, and it will help a lot of learners who are out there. So I want to move forward with the session, and I want to ask a question which is asked by Dr. Karan Bhatia in the chat box, and the same question I also had, and I had a little discussion with Dr. Varun, sir. So the question is, would you do anterior lens capsule ream polishing in such case, and the tips of doing in such case? Dr. Varun, sir, can you give us some points about that?
Yeah, so not just in a capsular tear, in normal cases also, I kind of agree with the view that Dr. Shail has. Anterior capsular polishing used to be given a lot of importance in the past, but now not so much. Uh, More so for a toric IOL, whatever studies there were have shown that not doing an anterior capsular polishing leads to an early sort of anterior capsular phimosis, which we would really want in a toric IOL for the lens to get stationed at one place. Also, the fact that the anterior capsule, wraps around the anterior margin of the lens, the posterior square edge lenses, they have the posterior capsule wrapping around the margin of the edge strongly. So it has, if it, if anything, it has shown a protective, effect for PCO formation subsequently. And I also, as a matter of routine, I have stopped doing the AC polishing, and I think more and more people are slowly moving towards that. Dr. Prashanth's opinion.
Yes. Can you share your views, sir? Dr. Prashanth, can
Hello.
you share your views on the anterior capsular polishing?
Yeah. Anterior capsular polishing is definitely important, especially when you're doing cases of pseudoexfoliation and also younger patients, where you can see the migration of the endothelial cells which are going to take place. And there was in 2017 or 2018, which paper was published, one of the techniques of polishing where they used to stain beneath after doing irrigation aspiration, they used to stain the posterior surface of the ALC with the blue. And they found that this also caused some amount of cell death, which takes place in reduction of the PCO formation. So it is one part. And of course, polishing is definitely, I think it is to be done, and especially some specific cases. In fact, when you're putting the premium IOLs and other toric IOLs, as well as the exfoliation, I think it is a must that we do a lot about polishing.
Yeah, I would like to add few things. I think for a normal case, if your axis is 5 millimeters, then there is no need to polish at all, because what I found it is that the anterior lens diameter is around 9 millimeter. So if you cross half of it, generally even if there is a fibrosis, it doesn't cause phimosis. So that in normal cases. But if you have very small rexis 4 and you are jittery to enlarge it, then might be for younger surgeon it's better to polish it off rather, but I would prefer that he enlarges it rather than keeping it very small like 4 or less than that. Second thing, cases where anterior capsular phimosis is very common is high myopes, extremely high myopes, retinitis pigmentosa cases, pseudo exfoliation, and very young patients. So in these cases, I would definitely like to do some anterior capsular polishing, but I think Capsulorhexis size matters a lot. So don't go for Capsulorhexis size less than 5 millimeter. You may land up in trouble with those. And also, if you are using hydrophobic IOLs, the anterior capsular phimosis is much less. That's what I have found, as compared to if you are using hydrophilic IOLs, where the fibrosis and the phimosis is very quick post-operatively. So for high myope cases, retinitis pigmentosa, pseudo exfoliation, if possible, use hydrophobic IOLs rather than hydrophilic IOLs.
So we have a question from Dr. Gunjan. She wants to ask, what technique does the panel advise in case of rexis extension in mature cataract at one point with rest intact rexis? Direct chop or phase in?
I think it's phaco in AC, I guess.
Yeah, so direct chop or you want to do phaco in anterior chamber?
I think
So anyone can take this.
we have to balance both. So her point is very valid that we are a little bit scared that if we try and stay in the bag, our maneuvering may lead this capsulorhexis to split. So do you bring out the nucleus and do that? But then we have to also look at the split side of it damaging the corneal endothelium permanently. So I think in such cases, a vertical chop definitely goes a long way. The horizontal chop, you're going behind the equator and bringing your chopper in. In vertical chop, everything is happening under your vision. So your chopper is just in front of your phaco probe. And if you try and maintain your, separating forces away from the possible area of capsulorhexis tear, and if we follow the principles that Dr. Patwardhan also highlighted very correctly, the principles of low parameters, I think it is as risky or as unrisky in a mature cataract as it was in my case, which was not a mature cataract.
Yeah, I would just like to add a few points, if I may. Uh, it's not as simple as having a tear in a mature cataract. What would you do? So while training, there've been multiple such occasions where such cases have occurred, and like in Dr. Shail's case, right at the beginning of the surgery, I used to always look at 3 points. A, where the tear has occurred. Uh, if it is opposite to your incision, then that will be in the direction of the force vector of the phaco and the chop. And that is bound to put more pressure on the area which has stone, and there is more likelihood of it extending posteriorly. If it is sub-incisional and you'll be chopping in the opposite direction or putting your phaco probe in the opposite direction, it's relatively safer. That's one tick that you can put and move ahead. Secondly, in mature cataracts or in patients who are slightly elderly, the zonules don't hold up so tightly, and there are higher chances of it extending posteriorly. In cataracts which are like up to NS2 or NS3, like in Dr. Shail's case, and in younger patients, the zonules tend to be slightly stronger and they hold the capsule and prevent it from extending posteriorly. So So, you have to take a view of the entire situation in entirety and then move ahead. So, yeah, I would look at these things and then probably take a call. And if it is, favorable in context of these things, I would move ahead and do it in the bag. And of course, like Dr. Shail said, a vertical chop is the technique that needs to be followed here, because that puts the least amount of vector forces around and outside and centrifugally, and it keeps the force between the tip and the phaco probe. And that is how you should go about it, I guess.
Yeah, I think I will add just one more point. If your capsulorhexis is very small and you have a radial tear, it's better to enlarge the capsulorhexis first, because many times you keep it small and then you do the manuals in the bag, it is going to extend it further. So first enlarge it on the other side. That will help you in even in conversion to small incision in case you have trouble with the radial tear. And second thing, I think in these cases, as we are maintaining low IOP, so deepening of anterior chamber is more, problematic for these cases than little bit of shallowing of the anterior chamber. That's what I have observed. So avoid sudden deepening of the anterior chamber. So even if you are changing your steps, make sure that the bottle height is low, because many times these motorized bottle heights are there. You change the step and suddenly bottle height goes up. It will deepen and then the tear will go to posterior capsule. So avoid sudden deepening of the anterior chamber. Whatever method you use is fine for removal of the or doing the cracks.
Yeah, and one more thing is that even during hydrodissection, since it is mature cataract, you can do minimal hydrodissection in multi-quadrant. And also during the phaco, as we're doing the direct chop technique with vertical chop, we should also try to do very careful rotation, or even minimal rotation, so that that rotation also wasn't taking care of this extension. It should be a particular point to check.
Excellent points. I want to ask next question to Dr. Shail. You manage this case very beautifully, but just if we imagine a different scenario, what if the radial tear is extended posteriorly during IA removal of the cortex? How would you have managed the case in that scenario? Can you give us some points on that?
Yeah, I think if you notice a posterior capsular tear, you must keep in mind that there will be vitreous unless proved otherwise. And however much experienced a surgeon one may be, it is impossible to actually see vitreous. So the first thing that all of us need to do is to inject preservative-free diluted triamcinolone acetonide to identify whether there is vitreous present or not. And if there is vitreous present, then whatever amount of cortex or fragment that is left, first we need to address that vitreous before we move on to anything else. Because if you feel that there is vitreous coming only from this side, let me remove the cortex from the other side, the fluid will keep hydrating, the tear will keep extending, and it will keep wrapping the fragments or the cortex that is there. So if you notice an extension, hold on, inject dispersive viscoelastic, inject triamcinolone, and first tackle the vitreous. Our preference is to do a pars plana approach of vitreous removal, but the point is to remove the vitreous whatever approach you are comfortable with, whether it's anterior route or posterior route. And once the vitreous is clear, then you can go ahead with removal of the rest of the cortex. And if you find that there is a margin from where you can hold it or grasp it and convert it into a posterior capsular axis, you can still consider placing an IOL in the bag. However, if it is a sort of triangle shaped extension occurring in the posterior capsule, and you feel either hesitant or not able to convert it into a posterior capsular axis, do not attempt to place an IOL of any form in the bag, and definitely not a single piece IOL in the bag, and definitely not a single piece IOL in the sulcus. So doesn't matter even if you have promised the patient that I will put this company's XY most expensive lens in the world. Do not come in that stress that now I have to put that lens at any cost. Then whatever will happen, we'll see what will happen 3 months down the line. So if in case of any large PCR, the safest and the best is to go ahead with a three-piece IOL in the sulcus.
So
Any other
continuing,
points?
Yeah, so continuing Nikunj's question, if in case we decide to convert this case, what will be the best approach? Can you give us some tips for that? Dr. Saurabh, maybe you can take this question.
Yeah, for the conversion. So conversion to small incision or the scleral, that's what you mean?
Yes, so
Okay.
whatever, whether you would extend the clear corneal incision or you'll make a scleral tunnel. So what will be your preferred method?
Yeah, I think just before we go to that, I think one particular sign which we miss mentioning in this case is the flap motility sign described by Dr. Rohit Om Prakash. I think that's very important. So when you have a radial tear going into zonules and you have decided to go ahead with phaco, you have to keep on observing these flaps which are torn. So if the flaps are everted, that means the tear is still the zonule itself, and if they are inverted and they are fixed, it indicates that the tear might have gone to posterior capsule. So I think that is a good sign, particularly in mature cataract, because you cannot actually see the what is happening posteriorly. So that is one sign we should look for. If the flaps get inverted and they are fixed, you have to convert at that point. The We can use both the methods. I think for beginners who are not well versed with small incision cataract surgery, best way is to just convert the nucleus. Very easy. And if you are good in suturing, I think you can get a good result with that. No need to panic about that. But if you're done quite a few small incision cataract surgery, because this is not like a routine small incision cataract surgery. So if you are, unless you are very good in creating tunnel in routine cases of SICS, I wouldn't advise that you suddenly make a scleral tunnel in this case. So be good in normal SICS and then you can convert it. So what is advisable is to avoid the same site of the incision. So for example, if you are doing temporal phaco, then it is better to move to head end and make a superior scleral tunnel. Now, one issue with these cases is that there might be some amount of hypertony, particularly because there is a rent and you cannot push too much of viscoelastic also in the anterior chamber, because it might just push the nucleus down into vitreous. So there is little bit of hypertony. So when you are creating the scleral tunnel, you have to go very slow. Don't try to go very fast. Create the tunnel well. Don't try to make a very small scleral tunnel, because here astigmatism is not an issue. Main important thing is to remove the nucleus very safely from the anterior chamber. That is the main concern. So just make large scleral tunnel. You can use 6.5 to 7 also. You can suture it later, so that you have very minimal astigmatism with that. And first prolapse the nucleus into the anterior chamber. It is better to use a sandwich method, or whatever method you are comfortable with for removal of the nucleus. So avoid pushing too much of viscoelastic. And if you are pushing viscoelastic, one mistake which I have seen surgeons make is that they push lot of viscoelastic over the nucleus also before delivering. That should be avoided in such cases. Just inject minimal, because if you push more anteriorly, the nucleus is pushed down into the vitreous and you may land up with nucleus drop. So that should be avoided. So make a large, nice tunnel and just let the nucleus float out of the anterior chamber. I think these are my tips for converting to small incision.
Yeah, thank you for answering that so well. Dr. Shail, I have a question for you. Do you think use of femtosecond for this particular case to make rexis would have prevented this?
So, there are pros and cons of each technique. I think the main concern with femtosecond was that, or is that this capsulorhexis, is it as strong as a manual capsulorhexis? And there have been now several electron microscopy studies done with the newer generation femtoseconds with lesser energy delivery. So, in the early on cases, the difference was huge between the strength of a manual capsulorhexis versus the femtosecond, where the femtosecond fared relatively quite poorly compared to the strength of a manual capsulorhexis. With the improvements in energy delivery and understanding of settings of how much energy to actually use, the difference in the strength has been shown to be quite minimal. So of course, in a standard case when there have been no bridges and a free floating capsulorhexis has occurred, the chances of it extending to or splitting are as good or as bad as having a very nice circular manual capsulorhexis, and somehow for some or the other complication intraoperatively, either with the chopper of the or the probe, you end up creating a split. So I don't think femtosecond is any longer more risky in causing anterior capsular tears than a good intact manual capsulorhexis.
Okay. I want to ask one question to Dr. Varun, sir. Sir, what if in the similar case, if the toric IOL is implanted and it rotates post-operatively, then what are the things to be careful about while re-rotating to the particular axis after in a case where the capsule tear is there with radial extension?
Well, basically, you have to inject copious amounts of visco. And if you have gone ahead with the cataract surgery with the tear, you have implanted the lens with the tear, then having to re-rotate the lens or having the lens get off from position 2 or 3 days later or even a week after, you don't really have to worry about the integrity of the capsule that much. And rotation is probably as you would have in a normal. Of course, you'll have to be a little more careful. You'll have to put in a little more visco. You have to make sure the friction is less and then try and wash out the excessive visco. But with such tears, the basic period to be careful or the basic period to worry about is in fact during the phaco and during the primary surgery. And a rotation in even, if you've seen the phaco through, if you've implanted the lens, the rotation is basically a simple matter. There's nothing extra that you have to take care of. You've already proved the fact that the capsular extension is not extending posteriorly. So you can have a relative amount of ease in doing that. But again, you have to have your guards up. You have to be careful. Extra visco, low tension, and yeah, go about it like you would do it in a normal anterior capsule.
The discussion is going on very interesting, but I think in interest of time, Nikunj, we may have to take one or two questions more, and then we'll have to close the session. So if you have anything to ask.
Just okay. Considering the time, I will take this question from Dr. Karan. I would like to ask Dr. Prashanth, sir, if he's there. Would you consider single piece hydrophobic IOL toric or non-toric in sulcus with optic capture if the case also has a PCR? Would you recommend that?
Yeah, I mean, in case of PCR, of course, as we have discussed, that we need to see the extent of PCR and which area of extension of the PCR is. Sometimes they say that the haptic has to be placed at the opposite direction of a PCR in case if it is there in the capsular bag that we are placing. That being a toric, then we need to know, depending upon the axis, where do you want to place is that. And if once we assess that well, and if we are able to place it in the bag, then sometimes there is an option of a reverse capsular capture that you can do also, which has been published by Dr. Gimbel in a specific case way back in 2014, where he has also stated that there is also helps in the decrease in the rotation of the toric lenses when you do a reverse posterior capsular capture, reverse optic capsular capture. With the haptics in the bag and the optic, above the ALC. That again, given the case, you have always the hypertropic shift and concepts like that we should be looking into. And of course, in large PCRs, of course, you can put a 3-piece IOL in the sulcus is one, which is going to be a safer way to manage the case.
I think just to add two things, I think regarding that question. First is no single piece in the sulcus. No matter even if you don't have a backup IOL, the conventional optic capture doesn't happen with a single piece. The design of the single piece is such that it's impossible for that optic to remain captured because the optic haptic junction is very bulky. And even if you manage to capture, it's that bulky optic haptic junction and the large haptics that cause all the uveal irritation. So no haptics of any, not even hydrophobic, not even hydrophilic, not even plate haptics in the sulcus of a single piece IOL. Reverse optic capture is an excellent technique. It's a very challenging technique to perform, and the most important thing is that you need an intact anterior capsulorhexis. So if you have a PCR which has occurred following an anterior capsular tear extension, that option obviously again is then ruled out. But capturing a single piece will work in exceptional cases. As a rule, if we have to advise as a rule, I would say three pieces still remains the surgery.
Adding on to Dr. Shail, you're actually right. I mean, putting a three-piece in the sulcus for a rent is one thing, but putting a three-piece in the sulcus for an anterior capsular tear is a totally different ballgame, because I mean, anyone who's actually captured a lens, putting it in the sulcus and putting it in the back, the amount of stress it puts on the anterior capsule is quite big. So if you have a tear in the anterior capsule, it's just not going to stick. It's going to keep slipping. So that is not really an option in this particular circumstance. But yes, for a PCR, it's obviously a best option.
So we have a question from Dr. Bhattar saying that what will you do if PCR happens and the case is under topical anesthesia?
It always happens that way. I think 9 out of 10 times it always happens that the patient is under topical, and it's the case where you least expect it to happen. I think two things. One is we need a good anesthetist. So a good IV, if an IV line has been taken, the anesthetic medication, systemic anesthetic medications in today's time are very, very good. I don't know too many details of them, but I do know that our anesthetics like to use a combination of midazolam and fentanyl as a cocktail. That does help to calm down and reduce the pain significantly. Second, for example, in our situation, we always use 1% preservative-free intracameral xylocaine. So in this case, we would also put on top of it a preservative-free 2% xylocaine on top of the surfaces. Some surgeons do recommend subconjunctival or subtenon xylocaine anesthesia at this point of time. But if you have never done it before, you'll probably end up creating more bleeding and more subconjunctival hemorrhage, creating more problems than it. So the patient will feel some pain, but and more surface, stronger topical anesthesia seems to work in more situations than not.
But practically, even in a topical, if you've used, say, even something like a paracaine and you use intracameral lignocaine routinely, you can go ahead and do a vitrectomy. And even if the case extends to, say, half an hour to 40 minutes, patients are generally comfortable. So it's not that big a problem. You don't have to look at it like, oh my God, it's like the end of the world. आप आराम से vitrectomy कर सकते हो. आप आराम से, you can go ahead and finish your procedure. Most of the times, the patients are, they tolerate.
Yeah, I think we have to give subtenon if patient is squeezing particularly. So if the patient is a squeezer, it's better to anesthetize. And I think I've shown it in one of my recent videos how to do that anesthesia. You just give little bit of subconjunctival anesthesia in the infranasal quadrant, and it's not at all painful because you already put paracaine. So just give zero point 0.1 to zero point 0.2 cc. Wait for at least 1.5 to 2 minutes. That wait is very important. Many times what we do is that we inject and we immediately go for next. uh, Xylocaine takes at least 1 to 1.5 minutes to act. So wait for 1.5 minutes, and now you nick open that area of the conjunctiva tenon. Take a blunt cannula and take around 2 cc of xylocaine, and just tell the patient that he will feel little bit of discomfort. Just go in the retrobulbar posterior subtenon and inject that. Again, wait for 2 minutes, and the patient will be absolutely comfortable for your whatever 30 minutes, 1 hour, whatever you want to take. So whenever you have, like for example, you have taken out all the nucleus and there is a small rent at the end, it's fine to continue on topical and patient is comfortable. If patient is squeezing, there is a nucleus piece there, it's best to give anesthesia, make the patient very comfortable and then continue. Otherwise, then patient is not comfortable, and then you also get that adrenaline whenever patient is saying something. You start speaking with the patient, and then your focus is not on the management of the case, but you have to keep talking with the patient. So I think this trick is very easy to do. There will be a little subconjunctival bleed, but it will go away. And you can remove the pad after 2 hours for xylocaine, and patient will have normal lead movement. So you can even discharge the patient.
One thing, not just for this patient, but all the patients, for all the people who are starting out young, please do a proper preoperative assessment of the patient's personality, and do not make topical surgeries an ego issue. Please do not hesitating in blocking the patient if you are even 10% uncertain, because that 10 seconds ka pain the patient's not going to remember. It's not going to put any blot on your, technical skills or your expertise, but you will basically have a peaceful and proper surgery. So patient assessment probably becomes more important in such a circumstance.
Over to you, Nikunj.
Yeah, so we have passed our time, but it has been a wonderful discussion and with a wonderful presentation. So I would like to congratulate Dr. Shail sir for his wonderful and excellent presentation with excellent management of the case. I would like to thank our panelists, Dr. Sourabh sir, Dr. Varun sir, and Dr. Prashanth sir for taking out time on a Sunday evening and giving wonderful tips for managing and preventing complications to the youngsters. So I would like to end this session by announcing our next session, which is going to be on refractive. So let me share my screen here. So next session of Surfing the Anterior segment will be on 28th of February on a Sunday, and last date of submission is 18th February. So, and the theme will be of refractive surgery. So I would like to invite anyone who wants to submit a video or a case presentation for the session from the audience, whoever is watching this. So uh, with that, we'll end the session here. And I would request all the panelists and Dr. Shail sir to stay back for a few minutes. And I would request the rest of the audience to leave the meet.